Welcome everyone, bienvenue. I'm Amy Sanders from DMI. Thank you for joining us for our event today. This event has simultaneous live translation. If you want to listen in English, please choose interpretation from your Zoom menu. The symbol is a little globe and select English. Si vous souhaitez écouter en français, choisissez interprétation dans votre menu. Le symbole est le petit globe et sélectionnez français. We have over 350 people signed up to attend today, and people are joining as I speak, a very distinguished panel. We're looking forward to a lively discussion on how we can accelerate progress in family planning. If you'd like to ask a question, please use the Q&A function in Zoom and type your question. You can ask questions as we go, and we'll share your questions with the panel in the second part of the event. If you'd like to tweet during the event, we'd be really grateful if you could tag @followdmi, all lowercase, and use the hashtag DMIFP, all uppercase. I think we can begin. It's my pleasure now to introduce our host for the event, Professor David Hayman. David is currently the Professor of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine and the head of the Centre on Global Health Security at Chatham House, London. For 22 years, he was based at the World Health Organization, where his most recent role was Assistant Director General for Health Security. Before joining WHO, he was based for 13 years in Sub-Saharan Africa. So we're in good hands today. Thank you so much, David, for hosting us. Over to you to kick us off.
Thanks very much, Amy. And, you know, as most of you know, there are about 218 million women in low and middle income countries who really want to avoid pregnancy but are not using a modern contraceptive method. And the Ouagadougou Partnership, which is a partnership of 9 Francophone countries in West Africa, has set a target of doubling contraceptive usage by the year 2030. What we're going to be talking about today is a randomized controlled trial of family planning that was run by the Development Media International Group in order to see how they could double the rate of contraception in West Africa. And what you'll hear today is a report of that study. And what I'd like to do now is turn it over to Roy Head, who's the Chief Executive Officer of Development Media International. But before I do that, I would just introduce the panel. And maybe the panelists could raise their hand when I call your name. Paul Kabatiba, former Prime Minister of Burkina Faso. Rachel Glenister, Chief Economist at the Foreign and Commonwealth and Development Office. Maria Ba, the Director of the Ouagadougou Partnership. Darren Welch, Director of Global Health at the Foreign and Commonwealth and Development Office. And Alex Zwane, the Global Innovation Fund, the Chief Executive Officer. So Roy, I'd like to turn it over to you now to give us an update on where we stand.
All I'm going to do, David, is to share my screen with you and show you a short film which just explains what happened in this trial. It's a simple way of explaining it. So I know that not everybody around the world will be able to hear it or see it perfectly, but we hope that at least 80% of you will be able to.
Having too many children too close together damages women's health and keeps families in poverty. More than 50 million women in sub-Saharan Africa want to choose when to have children, but don't use contraception. Even though modern contraceptives are more widely available than ever before, myths and social pressures stop women using them. How can we change this? Mass media can reach millions of people, but can it increase contraceptive use? Until now, no one has rigorously tested this. We ran a radio campaign in Burkina Faso, where 46% of women who wanted to plan their families did not use modern contraceptives. The campaign explained how the different methods work and how to have conversations with your partner about family planning. We ran a randomized control trial, the most rigorous scientific test available to evaluate the campaign. Our research partners, JPAL and IPA, interviewed over 7,000 women and found the increase in contraceptive use was 20% higher in the intervention zones compared to controls. Among women with a radio in the household, the impact was even greater. We measured our impact using 3 different data sources, including records from thousands of health centres. All showed similar results. The speed at which contraceptive uptake increased in the intervention zones was double that in the control zones. So it would have taken the control zones a further 2.5 years to catch up. Yet the cost of achieving this increased speed on a national scale would be just 7.5% of Burkina's national family planning budget. Compared to other countries in the region, the annualized increase in contraceptive uptake was much higher. So mass media can increase contraceptive use and help women plan their families. Taken to scale, this could improve hundreds of thousands of lives.
Thank you, Roy, for screening that explainer film. I'd like now to turn to Paul. Paul, I'd like to ask you if you would set the scene for us and talk about the importance of family planning for countries like Burkina Faso. So Paul, over to you.
Merci beaucoup. Bonjour à tous. Très heureux d'être parmi vous aujourd'hui et de dire que le Burkina Faso aujourd'hui, nous sommes dans une situation qui est caractérisée par un taux de croissance démographique de 3,1% par an. Nous avons une population déjà qui compte, selon le dernier recensement, 20 millions d'habitants et avec un taux de croissance naturelle de la population de 3,1% par an. Nous avons également l'un des taux, en tout cas de fécondité des femmes, qui est le plus élevé en Afrique, puisque une femme donne naissance en moyenne à 6 enfants, à un peu moins de 6 enfants. Selon les statistiques, c'est entre 5, 4 et 5, 7. Ce qui veut dire qu'à ces rythmes-là, le taux de croissance démographique deviendra simplement insoutenable dans quelques années, compte tenu des besoins économiques et des besoins sociaux que cela induit, sans compter le coût humain qui est lié également au problème des décès. Selon les dernières statistiques, on a à peu près 334 décès de femmes en couche pour 100 000 naissances vivantes. Et sans compter que les besoins sociaux, les besoins économiques augmentent. Parce que moi, quand j'étais au gouvernement, je me suis aperçu que nous avons une population composée essentiellement de jeunes. Parce que vous avez à peu près la proportion de ceux qui ont moins de 18 ans représente à peu près moins de 60% de la population, on fait à peu près 58%. Et la population qui a moins de 25 ans représente déjà un peu moins de 70%, ça fait 67%. À ce rythme-là, quelles que soient les politiques volontaristes que vous allez mener pour résorber les besoins en santé, en éducation, les besoins en infrastructure, ça devient difficilement insoutenable pour le budget de l'État, compte tenu de l'évolution donc très importante de la croissance démographique. C'est pourquoi mon gouvernement avait déjà entrepris, sous le leadership du président Christian Kaboré, dès que nous sommes arrivés aux responsabilités, de mettre en œuvre une politique volontariste pour essayer en faveur donc de la planification familiale. Ça, c'est ce que je voulais dire en introduction, on peut aller un peu plus dans les détails. Et c'est pourquoi également, à partir de 2017, on avait mis en place le plan national d'accélération de la planification familiale. On peut aller dans les détails, mais en tout cas, le contexte, c'est cela. Il y a clairement un engagement très net du président du Faso, le président Christian Kaboré, et du gouvernement du Burkina Faso pour la planification familiale. Merci, David.
Thank you very much, Paul, for giving us a good understanding of the family planning situation and the fertility situation in Burkina Faso. I'd like to now turn to to Roy and ask Roy to tell us a little bit about the randomized control trial and why you set out to do this in Burkina Faso. What was the real problem you were trying to address?
Well, I think that for anyone working in mass media and international development, we have a burden of proof problem. So no one disputes that mass media reaches millions of people, but there's been, until recently, no scientific proof at all that it actually works, that it actually changes behavior. And indeed, the nature of the intervention that we do, which is entertaining programs vanishing into thin air, I mean, there's no wonder that people prefer to spend money on building hospitals or paying for drugs or doctors, and we know they work. Now, we did a trial that ended in 2015, and it was the first trial to show that mass media could change behaviors, and that was focusing on child survival. And there was a 56% increase in malaria treatment and a 9.7% reduction in mortality. And so that went some way. But family planning, as Paul outlined, is just as serious an issue, and yet it's so much harder. I mean, how many children you have speaks to your relationship with God, with your status as a man, your status as a woman. It's highly sensitive. So we weren't at all sure that this would work. The intervention that we did was very much based on saturation principles. So we were broadcasting 10 times a day, plus interactive programs 3 times a week. And that compares to most media campaigns are really done just a few times a week, just a few little spots scattered here and there. And it's really not enough to make a difference. And I should also add that there were already many family planning interventions going on in Burkina Faso, including media campaigns. So our impact that Rachel will talk about is over and above the sort of standard level of sort of media campaigns, if you like. I'll just say a couple of things about messaging. There's lots to say, but here's 2 features. I mean, part of our messaging was motivational. So we were trying to, for example, encourage birth spacing. I mean, there was one story that we did. It was a man, he was in a boat and the boat was sinking and he was starting to be surrounded by crocodiles. And he called out to his brother-in-law on the other side of the lake, said, "Help, help." And his brother-in-law said, "You stay where you are. You made my sister have a baby every year for 6 years in succession. She begged you not to. She even got sick and you didn't listen. It's best you go down with the crocodiles." And then the spot goes on and eventually the man repents of his ways, promises to be different, and he gets rescued. But it was interesting that callers after that program to the radio stations actually said that we should have let the crocodiles eat him. Another aspect of our campaigning that was interesting was myths and side effects. And we all see this every day now with COVID. But one of the biggest myths around family planning is the loss of fertility. And one of the most common side effects of, for example, the implant is that a woman loses her period for 3 to 5 years. Now, in a context where menstruation is a strong sign of fertility and fertility is really important, this could be absolutely prohibitive unless it's understood. So our aim was to be honest about side effects. So that includes period stopping, weight gain, heavy bleeding, so that we could also be honest about myths. So myths included the IUD or implants becoming lost in the body. And we often asked MSI, Marriage Service International experts, to come on our programs and give real expert advice. And the final thing I would say is that it's about cost effectiveness. You can only really measure cost effectiveness and whether this is worth spending money on. And that was the first question we started out with. Is it worth spending money on mass media when you know whether it actually works? And knowing whether it actually works or not is only possible really with an RCT. I don't think we were ever postulating that mass media is more effective than supplies. The supply side is crucial. In fact, we would have had 0 impact without supplies of contraceptives in health centers. All we did was drive people to health centers where they got the contraceptive supplies. So it's not an either or. The question mark here is whether improving the demand side is a valuable add-on. And I think that's the question we were setting out to answer.
Thanks, Roy. Rachel, let me turn to you. I believe you had a role in designing and setting up this study and evaluating, despite all the myths and the crocodiles and the cost. Exactly what did you do and what were the results?
Thanks. And I should say it was very much a collaborative effort of everyone in DMI and the research team, which included Joanna Murray, who's at DMI, and Victor Pouliquin, who is now at Oxford. So what we did, as Roy was saying, it is quite hard to really rigorously measure the effect of mass media campaigns because they're mass. I mean, you're hitting, you know, thousands, millions of people with the same message at any one time. So what we did was, first of all, the mass media campaign was run in some radio stations and not others. So that picked of 16 radio stations, 8 were randomly picked to run the mass media campaign. Now, that's brilliant that you could look at it at, you know, different parts of the country getting different messages, but it's still only 8 treatment and 8 control groups. And that kind of worries us statistically that, you know, that's not a massive sample. So we also took within intervention areas with many women didn't have access to a radio. So of the women who didn't have access to radio, we randomly gave some a radio. And then you are at the individual level, we were able to compare some then had access to the mass media campaign and some didn't within the same area. So that gave us a completely different lens on looking at the impact. And finally, as Roy said, we looked at the what the clinics reported people used, how much contraception they used. So we have these 3 really independent ways of looking at the problem. And fortunately, they all tell us the same story. And that really strengthens my confidence in the results, that 3 different ways of looking at the problem came up with really remarkably similar results. So what did we find? Well, we found that in the campaign areas, you saw an increase in the use of modern contraception of 5.9 percentage points, which is a 20% increase on the control areas. If we compare the women who got a radio and didn't get a radio in the same area, you get an increase of 5.8 percentage points. So really almost identical. There was, as I say, completely different independent way of looking at it. I think what was most interesting and maybe surprising about it was what we learned about how it worked, how the mass media campaign worked, which was that we see the main effect coming from women who had used some contraception in the past. And it mainly happened through addressing those myths about contraception. So it wasn't changing fundamental views about gender. It wasn't changing your views about how many kids you wanted, actually. But even just addressing those myths, it changed the behavior of the people who are kind of at the margin. They were using contraception inconsistently. So, you know, it had the biggest effect on women in the range of between sort of 30 and 45, and it worked through increasing knowledge. So 9 percentage points less likely to say that modern contraceptive methods can make a woman sterile. 8.4 percentage points less likely to say it can cause sickness. And women were more likely to say they're likely to use contraception through their life. But as they say, no effect on these sort of fundamental fertility preferences. And I think that really has a quite important policy implication for the world, not just on mass media, which is, you know, that mass media is a really important way to deal with issues of modern contraception, but also that maybe we ought to be focusing a lot on these women who are kind of on the edge, and we can address these myths. I mean, there's a lot of discussion at the moment about, you know, misinformation. There's always been a lot of misinformation about contraception. And it looks like mass media is a really effective way of addressing that misinformation.
Thank you, Rachel. A very interesting study. Paul, what was your reaction to this study, and what was the reaction of the government in Burkina Faso to the study results?
En ce qui concerne le gouvernement, je n'ai pas encore eu connaissance d'une réaction officielle sur la publication des résultats de l'étude. Peut-être que c'est lié au fait que l'étude encore est très récente, hein, puisqu'elle a été publiée, semble-t-il, simplement au mois d'avril. Peut-être qu'il faut laisser le temps aux spécialistes et au gouvernement également d'en prendre connaissance avant de pouvoir réagir. Pour l'instant, je n'ai pas encore eu de connaissance de cette réaction. Mais ce que je voudrais dire, c'est que, à mon avis, on pourrait en parler plus tard, ça pourrait être utile qu'on puisse organiser une sorte de forum, à Ouagadougou, ou bien à Bobo, ou dans les villes du pays, pour essayer donc de partager sur la méthodologie qui vient de nous exposer Rachel, sur la méthodologie de déroulement de l'étude, les principales conclusions et les recommandations également en matière de family planning. Je pense que ça pourrait être une bonne façon de partager ces résultats avec les Burkinabés, et ça pourrait être également une façon également d'interpeller aussi peut-être le gouvernement sur cette question aussi importante, c'est le family planning. Parce que ce qui est certain, c'est que plus il y aura une prise de conscience au niveau de la population qui sera élevée, plus nous, les politiques, en tout cas, on sera dans l'obligation de pouvoir apporter des réponses. C'est vrai, comme je l'ai dit dans les propos liminaires, il y a le plan national d'accélération du planning familial qui vient de prendre fin. C'est de 2017-2020, mais on n'a pas encore une évaluation complète de ce plan. Puisque l'ambition, c'était de porter le taux de prévalence de la contraception moderne de 22,5% à 32%. Alors, on n'a pas encore une évaluation des résultats. Et alors, je pense que l'idée de faire une sorte de forum sur cette question peut être intéressante. L'idée également, peut-être, d'avoir un forum aussi un peu plus au niveau des spécialistes des questions d'épidémiologie et de santé publique sur la question. Je ne sais pas, peut-être là, ça pourrait peut-être aussi donner un peu plus de force, hein, au rapport qui a été fait, à l'étude qui a été faite. Et ça pourrait être, je pense, des institutions comme l'UNFPA, des institutions comme l'Organisation mondiale de la santé, qui pourraient également être interpellées pour donner leur point de vue par rapport à l'étude qui a été faite. Je pense que ça donnerait je ne dirais pas de la crédibilité, mais en tout cas un peu de force politique à ce qui a été fait. Et ça pourrait également inciter le gouvernement en tout cas, à prendre en compte les conclusions qui ont été faites. Mais à titre personnel, je voudrais dire que j'ai été surpris par les résultats de l'étude. J'ai été surpris de voir qu'une étude de ce type basée sur les médias radio a permis, dans les zones qui ont été retenues, de faire passer le taux d'utilisation de la contraception moderne, de la faire augmenter de 20%, c'est considérable. Puisque j'ai vu également que porté à l'échelle, ça faisait une augmentation de 225 000 femmes à l'échelle du pays, c'est considérable. Donc moi, au vu de cette étude, je suis vraiment enthousiaste et convaincu à l'idée que le support, le vecteur média, singulièrement le vecteur de la radio, qui est le plus répandu dans mon pays, peut être un puissant levier de changement de comportement. Merci.
Thanks very much, Paul. Roy, what do you think of the idea of a forum, and how does that play into how you will diffuse these results eventually within Burkina Faso and also within Africa?
Roy, excuse-moi, tu dis?
Sorry, can you hear me now? Yeah, I think that'd be a great idea.
Très bien, oui.
And we'd love to work with Paul on that. And I think that everything that we do is trying to benefit the region and including the whole region of Africa, really, as best we can. The idea of DMI is we test, then we scale. And we've been very lucky that one of the donors who contributed to the RCT, the scientific study, has also financed the scaling up in Burkina Faso of the family planning project. So it already is, we're running right now at scale, national scale in Burkina Faso. And thanks to the FCDO, we've also been able to scale up in 7 other African countries. So it's been a lovely combination actually to do the study and then have the funding to take it to scale. That's been a real plus.
Thanks very much, Roy. Maria, I'd like to turn to you now. You're the chief executive of the Ouagadougou Partnership. And I wonder what the lessons are for you in this study, how you might feel this could be applied within the partnership. And maybe you could talk a little bit about that partnership as well. Maria?
Thank you very much, David. And to us, this study and the results of this study are extremely important. There is and has been latent demand for progress in meeting such demand, as you pointed out. So our countries have
Maria, your screen is freezing.
And investments, both foreign and our ministers of health and civil society, youth, religious leaders are to be recognized and congratulated for. Now, in some countries like Senegal, for example, we've now hit some sort of a bump in terms of against the demand curve in some regions. And so at the same time, we're optimistic and have a lot of evidence that show that when we increase services in an area and quality services and counseling, I might add, demand also rises. So we're engaging with a number of exciting social behavior change approaches with our community leaders that are paying dividends. We know that with this ambitious new goal that we have of doubling the number of additional users of modern methods of contraceptives, that is going to take having to do things differently. And we want to focus more and more on demand creation, on social norms, on social behavior change. And the results of this campaign are extremely important to us in that sense, showing evidence that mass media does impact and is a good communications tool to increase uptake of family planning in general, and also the contraceptive prevalence rates as well. So we've heard, for example, from a lot of our constituents and stakeholders that they don't want to hear about pilots anymore, at least once we know what works. And I think having this evidence now is going to be easier to you know, in terms of domestic funding or foreign funding, to be able to scale up. And I would even go a step further than Mr. Thieba is actually, you know, having a forum for Burkina Faso and scaling up in Burkina Faso is one great idea, but also scaling up to the 9 OP countries. When we know that the desire for children, for example, in certain countries like Niger is about 11. So those are the areas that we also want to target. And so we're very excited about this study.
Thanks very much, Maria. Roy, I'd like to come back to you for a minute, because I think you talked about the child survival activities that DMI did previously in increasing health-seeking behavior, and also the now the randomized control trial. And I just wondered if you thought that these two would mix together in any way in the future, and maybe others would like to comment on that as well, because child survival is certainly one of the keys to successful family planning as well, I would think. Roy, do you have any comments on that? And then I might go to Rachel and back to Marie on that, and to Paul, of course. You're muted.
Okay, can you hear me now? I mean, there obviously is this historical trend that as children survive longer, then parents don't need to have so many children, and in order to allow them to survive economically, particularly in their later years. So there's clearly a link there. And you do say, while you're saving children's lives, you save mothers' lives. There's the maternal health and child health are deeply linked, and there's a strong connection between family planning and birth spacing and the mother's health or the mother's survival. But I would defer to Marie and Rachel actually to talk about, you know, what's really necessary in these countries.
Thanks. So maybe Rachel, I'll turn to you and then to Paul and get his reaction as well to the Ouagadougou project and to how DMI might fit into both the project and maybe the other activities with child survival.
Yeah, thanks. So a couple of things. I think it's, Marie talked about, you know, people not wanting to do just pilots anymore. I mean, one thing to note is this pilot was on a massive scale to start with. It's, you know, bigger than the size of many projects as just a pilot with millions of women participating. And as Roy says, it has already been scaled up in Burkina Faso. But I think it would be fantastic to bring it to other countries in the region. I mean, one thing, talking as, you know, a researcher, it was not effective in this context of changing preferences for children, but there are still a lot of, as we heard, millions of women who want to use family planning but don't. And understanding through this that one of the reasons was, you know, the myths about the downside. I think the links with child survival are many. You know, as children survive more, people want to use contraception more, but also we know that as women have fewer children, they invest more heavily in the children that they do have, and they have better education opportunities, better health. And so there's sort of this virtuous circle that you get of, you know, child survival, improving demand for contraception, use of contraception, feeding back into better child survival. So you get this really positive effect. I did want to mention the cost effectiveness of the scale up, because one of the unique positions we're able to do here, often where we're projecting cost effectiveness at scale, we're kind of guessing about the numbers. But here, because there was a scale up, we could actually look at what the cost effectiveness of the scale up was, and it was really remarkable. So $7.7 per additional women using modern contraception, which compared to, you know, or other studies of other interventions, it really, you know, it's really very, very cost effective. So as I say, and that's not just a hypothesis, it's, you know, based on the real numbers of what it costs to scale it up.
Thanks, Rachel. Paul, do you have any observations on the scale up? And then I'm going to come back to Maria for a few words on how she feels this can continue. So, Paul, any comments that you'd like to make?
Oui, je voudrais dire que je partage tout à fait les idées qui ont été développées par Rachel tout de suite, parce qu'effectivement, je pense que, oui, vous savez, ici en Afrique, en tout cas au Burkina Faso, l'une des raisons pour lesquelles nous avons tendance à avoir un nombre d'enfants par femme très élevé, c'est lié à tout ce qui a été dit. C'est-à-dire qu'on s'est dit, bon, compte tenu du taux élevé de la mortalité infantile, il vaut mieux en avoir toujours, on ne sait jamais. Deuxièmement, l'autre point de vue, c'est que pendant longtemps, n'oubliez pas qu'au Burkina Faso, nous avons 70% de la population qui est encore rurale. Les gens ont encore besoin de main-d'œuvre pour aller travailler dans les champs. On fait beaucoup d'enfants pour avoir la main-d'œuvre pour aller travailler dans les champs. C'est maintenant que les choses commencent à changer. Mais je pense que cette étude, le lien en tout cas avec la mortalité infantile, et pour moi, il est là. Moins les femmes feront d'enfants, plus elles auront de moyens pour s'occuper de l'éducation de leurs enfants, de la santé de leurs enfants, de leur suivi, et toute la société en bénéficiera. Je pense que ce lien-là, en tout cas, il est difficilement discutable. Et je me rappelle que lorsque j'étais au gouvernement, l'une des raisons pour lesquelles on a mis en place la gratuité des soins pour les femmes enceintes et pour les enfants de moins de 5 ans, c'était justement cela également. Ça visait à faire en sorte que, en réduisant la mortalité donc, maternelle, en réduisant également la mortalité infantile, on pensait créer ainsi une sorte de dividende qui permettrait donc aux familles de mettre plus d'argent dans la prise en charge des frais de santé, d'éducation et des enfants. On pensait ainsi que les choses allaient en tout cas s'améliorer au niveau global pour l'économie nationale également. Parce que lorsque je suis arrivé au gouvernement, j'ai constaté qu'on a un taux de croissance du produit intérieur brut, du PIB, de 5,5% en moyenne depuis 1970. 5,5% en moyenne depuis 1970, taux de croissance moyenne du produit intérieur brut. Mais je me rends compte que lorsqu'on rapproche le taux de croissance du produit intérieur brut, quand on le rapproche par rapport au croît naturel de la population qui est de 3,1% par an, ça nous amène en réalité à un taux de croissance du PIB par tête d'habitant de 1%, 1,1% par an. Ce qui veut dire qu'en réalité, l'économie est stable. C'est pourquoi mon gouvernement, sous le magistère du président Roch Marc Christian Kaboré, considère que la question de la planification familiale est centrale dans notre quête de développement. Et nous pensons que s'engager vraiment dans ce processus, maîtriser ce processus, c'est une façon de lutter contre la mortalité maternelle, de lutter contre la mortalité infantile et également de tirer les dividendes pour toute l'économie nationale et pour la société. Et je suis convaincu que l'élan qui a été donné lorsque j'étais au gouvernement de 2016 à 2019 se poursuit encore aujourd'hui à travers donc l'action du président du Faso et des ministres qui ont pris le relais, notamment les ministères de la Santé, etc., qui travaillent sur des sujets. Il y a clairement ici au Burkina Faso aujourd'hui un consensus fort sur cette question. Merci.
Thank you, Paul. Maria, do you want to close out on this session with a few more observations?
Sure, and then I completely agree with the rest of my fellow panelists on the impact that this has not only on the contraceptive prevalence rate, but also on maternal and child mortality, the link to child survival, to economic empowerment, and not just for women, because they're potentially half of your workforce. So I really have never understood how we could just put aside having that increase in terms of a workforce. But to come back to maybe the Ouagadougou partnership, I think one of our big focus for our vision 2021 to 2030 is on addressing social norms and social behavior change. And so for us, these sorts of campaigns are what can make a big difference. It's the one big area that we want to focus on for Beyond 2020 strategy. And so we've seen that we've used up the gains, if I may say so, in terms of service delivery and the impact that it has. We do have still some efforts to make in terms of the supply chain and all of those issues, but also on creating demand. We think that's where the next frontier is. It's going to be challenging because we're dealing with a set of social norms. And I think one great point that Rachel made is that it not only increased the uptake of family planning and contraception, but it also helped address a lot of the myths that are barriers to family planning. And to us, that's probably one of the most important aspects. For women who are not aware yet that they do want family planning because they hear so many horror stories in the health centers, for example. For other women who know that they want family planning but are scared of the reaction of their relatives, their family, their husbands also, who are believing some of the myth. That is where I think a lot of the impact can come from in terms of these mass media campaigns and being able to provide evidence that it works and getting funding for that. and making sure that we're addressing and changing these social norms, and ultimately leaving the decision, as I say, to couples or women, but at least that they have the right information and they can base their decisions based on that.
Thanks, Maria. So I think DMI is well placed to support both family planning and, in addition, child survival activities, which are certainly, from what I hear, synergistic moving forward. And I think that's quite an important move forward. I'd like to turn now to Darren, though. Darren, you're from the UK government, and the UK government has certainly played a major role in advancing family planning throughout the world. And I wonder if you could talk a little bit about your WISH program, the Integrated Sexual and Reproductive Health Program, and what you think answers are for accelerating progress in this project beyond just the supply of contraceptives. So Darren, over to you.
Thanks, David, and thanks for the invitation to take part in such an interesting discussion. And we're so proud to have been associated with this study, which has given us these really interesting insights and results. The UK has got a long-standing commitment to work on comprehensive sexual reproductive health and rights and family planning as part of that. And I think you'll see that coming through quite strongly in the G7 work we're doing at the moment, as well as what we're going to be doing through the Global Equality Forum. There's another great opportunity this year to make some progress on these issues. It's been a tough environment, I have to say, in recent years, and it's needed countries to stand up and make the case for greater rights, SRHR, and for family planning. We've had 2 family planning summits in London. It's long been an issue that we have championed, and we've been strongly supportive of the work of FP 2020 as well, which I'd like to refer to. We've seen their final report recently, which showed that in those countries where there were commitments made, there's been much greater progress, and now there are 60 million additional users of modern contraception compared to 2012, and the rate of growth has been most in Africa, where the rate's gone up by 66%. So there's been a lot that's been achieved, and we're proud to have played our part in that, and the WISH program has been an important contribution. And our approach generally has been to integrate SRHR and family planning into our work on system strengthening. That's going to be the mainstay of our work on sort of global health, strengthening our systems globally. Increasing supply, and we've talked about that a bit, building that demand, and this is where the results of the study are so helpful. Advocating for rights, I should acknowledge the work of the Partnership for Maternal, Newborn and Child Health in this respect as well, the great advocacy work they're doing in many countries, and then generating the data and accountability to make sure that we've got really good evidence base and that we're holding leaders, people are able to hold leaders to account for the things they say they're going to do. It's a really important area for us, and I think Paul and Marie gave some indications of why that should be. It's essential for achieving many of our development objectives, maternal health, child health, education, economic transformation, demographic transformation, so many different issues. So I think we've come a long way, but there's a lot more that we need to do. And I think it's been put well by the FP 2030 partnership in terms of the future directions and your point about what we can do to accelerate progress. I think strengthening systems is going to be really critical, focusing on delivery of quality services and supplies. The policy piece will remain very important to us as well, getting the right policy agendas in place that are supportive of family planning. Financing, there's no way around that one. Increasing, diversifying, and making sure we get the very best value from the financing that is available. Transforming social and gender norms, generating that demand which we've been talking about, and then driving the data and the evidence-informed decision-making, and that's where the RCT results come in. But none of this is going to happen without country governments in the driving seat, firmly, really committed to delivering this agenda. And it's been so encouraging to see what's been achieved in Burkina when you do have a government that takes on that leadership role. Thank you.
Thanks, Darren. And I think we have seen the commitment of Paul and the government of Burkina Faso to this. As you say, government commitment is very important. I'd like to now turn to you, Alex. You at the Global Innovation Fund actually took a risk in providing support for this trial that went on. And I wonder what your observations are now. Why did you take the risk? And what do you feel now that the risk has been taken and the study completed?
Well, thank you very much. And thanks for the opportunity to be part of this very rich conversation around a very important topic. It's certainly true that there was some risk in funding this impact evaluation. It may have been, the true risk would not have been that we learned that this mass media campaign did not work. Indeed, that sort of information would have helped you to reorient scarce resources towards something more effective. The risk that was inherent in this would have been an uncertain result, that this did not provide guidance about whether this was effective or ineffective, but simply that we were uncertain. And it was an appropriate risk to take precisely because of the potential for impact that we've been talking about here. Not only if we were able to discover something that was particularly effective, there would be benefits for women and children and future generations. And of course, with a mass media campaign, there was the potential for this to be highly cost effective. I very much appreciated my colleague Marie's comments that we're sick of pilots. And that was another risk that we certainly took on, that a promising result might generate a little flurry of excitement, but then there would be a gap in funding or in initiative or will to take this promising pilot to something really delivering all that impact at scale. So it's wonderful to hear that private donors have stepped up for funding the scale up of this program in Burkina. What comes next, though, is localization. As my friend and colleague Darren has said, local leadership, local ownership, local integration of this approach into government programs and government budgets with government in the driver's seat is ultimately what I think our goal around this topic is. In terms of what comes next then, for this particular program, that's a wonderful goal for us to all have. And it's the leadership of folks like Marie and Paul who will make that happen. And I'll just end by mentioning what Rachel talked about misinformation as a general and pervasive issue that inhibits the take-up of public health products and technologies and innovations more generally. I think we see here that some of what DMI does can be thought of as a platform on which you can layer correct information about a variety of different topics. And so we're very keen to see this innovation be further exploited to address other kinds of misinformation that unfortunately is pervasive and it does inhibit take-up of important technologies.
Thanks, Alex. So Darren, let me come back to you. You've seen the outcome of this randomized controlled trial and the evidence that it's really provided. What else needs to be done? What are some of the other roles in randomized controlled trials that you see moving forward?
Yeah, thanks, David. So look, resources are always constrained. Perhaps they're particularly constrained at the moment as we are focused on dealing with the impact of the pandemic. So having evidence of what really works is perhaps more important than it's ever been, and that's where the RCT is so helpful, and it provides really strong evidence on how we can use mass media to normalize and encourage the use of contraception. Now, the results perhaps couldn't be entirely replicated in other environments, but there are really important insights and evidence which is giving us, which I think are of wider application, how we can affect behavior change and wider community acceptance. I think this is a sector which does put high value on the use of evidence, and we're quite fortunate that there are a number of resources and some brilliant organizations which are generating evidence. Just to mention a couple of them, we've got the USAID funded high impact practices work, a set of evidence-based family planning practices. We've got obviously the work of the Guttmacher Institute, and then programs like our own WISH program are generating evidence which you need to get out there and into the bloodstream of the sector. So I think there's a need now to collate and to publicize and to make available that evidence base and continue to grow it. If I'm thinking of other areas actually where we need to understand how the provision of information can change behaviors. And we talked a bit earlier about misinformation. Well, there are a number of sectors where misinformation is a problem. One I work in is around vaccines, for example. You know, are there insights from what this has produced so we can test and trial for greater benefit in other sectors? I'll stop there. Thanks.
Thanks, Darren. Marie, let me come back to you now. You're sick of pilots and you want to see something really scaled up now throughout the Ouagadougou project. How will you take the evidence that's been generated by this trial and really engage the political leaders in the Ouagadougou project?
Thank you, David. And I see that my comment has struck a chord. And I really meant for pilots that work. I think it's very important to test out. Obviously, scaling up, to the 9 countries at once might not be the best idea. In terms of the interest in, I think we've already seen the interest of local leaders, local organizations, and the ministries of health, recognizing we do hold these annual meetings at the end of every year, where we have an evaluation of where we are in terms of adding additional women users, but also in terms of contraceptive prevalence rates and the commitments that the countries have made. And I think at the local level, the country level, they've already realized that we have hit a bump in the results that we have, and that we need to now focus on demand creation. That was the topic and the theme for our last annual meeting. So we wanted our stakeholders to be a little more aware of what we mean exactly when we say that we want to address social norms. There's this connotation sometimes that it means importing certain behaviors into Francophone West Africa, and that is not the case. So I think for people like us, like Alex has said, and certain global health leaders in the Global South, I know the term Global South also gets a bad rep sometimes, but being able to explain exactly what is meant by addressing these social norms. So I think there's already an appetite from at least the leadership that then needs to be translated into the women and the populations, and especially the youth also. We want them to fulfill their roles as agents of change. They've been asking for this also, being in the driver's seat and deciding of their own future, and sexual and reproductive health and rights is also extremely important to them, because they do realize and understand the impact that it has then on the economic development. And I think, as Mr. Thieba was saying, when your demographic development is going much faster, that it doesn't matter how many percentage point you add to your GDP, you just can't catch up, and you never have enough health centers, you never have enough schools for youth and children. And what is a country really without an educated youth? So I think there's already that appetite, but for us at the Ouagadougou Partnership, we're invested into continuing the advocacy and the resource mobilization for these sorts of action. We've started a little, but I think having this study and these results and this evidence is going to make our advocacy work a lot easier.
Thanks very much, Marie. And Paul, can you add anything more to the discussion about engagement of the political leaders, and also about any cultural changes that might be occurring that will facilitate this moving forward?
Tout à fait, tout à fait. Je pense que ce qui a été dit tout à l'heure est tout à fait fondamental. Je partage ce que Maria a dit. C'est vrai, il y a en Afrique des normes sociales auxquelles il va falloir, en tout cas avec lesquelles il va falloir faire reculer. quand vous allez dans les zones rurales qui composent 70% de la population de Burkina Faso, dans ma région, par exemple, au nord, ceux qui connaissent le Burkina Faso, il y a une forte emprise des religions sur les comportements et sur les mentalités. Il me semble qu'il sera important de pouvoir dialoguer avec les communautés, avec la communauté musulmane, pouvoir approcher la communauté musulmane dans le cadre d'un dialogue ouvert, équilibré, échanger un peu sur la problématique de la planification familiale. C'est la même chose également pour les autres confessions religieuses, hein, les protestants, les catholiques, de manière à impliquer les communautés dans la problématique donc, de la planification familiale. C'est fondamental parce que dans ces zones rurales, là où l'État central n'est pas très présent, seule une prise de conscience au niveau des communautés peut amener des changements de comportement. Et je pense qu'à ce moment, donc, l'utilisation des médias, donc les radios, les télévisions, et l'organisation de forums locaux, dans les chefs-lieux de province, dans les villages, ça peut avoir un impact sur les changements de comportement. Mais il faut travailler avec les communautés, comme l'a dit Mariba, pour faire reculer également les préjugés, faire reculer les normes sociales qui sont souvent, voilà, qui entretiennent souvent voilà, les comportements qui sont contre le planning familial. Ça, c'est extrêmement important. Il faut vraiment une approche sociologique et culturelle pour pouvoir faire reculer ces choses-là. Alors, je pense également que, à côté de cela, il va falloir également travailler avec les associations de jeunes, la société civile, comme ça a été dit, de manière à ce que les jeunes, les sociétés civiles s'impliquent dans le combat pour la planification familiale. Ça, c'est pour le côté de la demande. S'agissant du côté de l'offre, il est impératif qu'au niveau de nous qui sommes dans les instances gouvernementales, il est important que l'on mette l'accent sur la qualité de l'offre, mais également sur sa disponibilité, notamment dans les zones rurales. Là aussi, dans les zones rurales, il va falloir que dans notre politique de santé, on arrive à faire en sorte que on puisse disposer donc de personnes qualifiées dans les échelons, dans nos structures de santé les plus reculées. Au Burkina Faso, ce sont ce qu'on appelle les CSPS, ce sont les centres de santé et de planification sociale. Les CSPS, il faut que dans les CSPS, le personnel qui est en contact direct avec la population puisse être sensibilisé à la problématique de la planification familiale. Il faut également que dans ces centres de santé et de protection sociale, il faut également que les sages-femmes, les matrones, les infirmiers, les infirmières soient sensibilisés à la problématique de planning familial de manière à ce qu'ils puissent sensibiliser également l'essentiel de la population avec lesquels ils sont en contact direct. Donc, je pense qu'il y a une approche multidimensionnelle, aussi bien du côté de l'offre que du côté de la demande. Du côté de l'offre, c'est la responsabilité de l'État et des services de santé, mais du côté de la demande, là, effectivement, je pense que nous avons tous une responsabilité à assumer, et c'est pourquoi je pense que c'est tous ensemble que nous pourrons réussir. Et c'est pour ça que je suggère qu'une étude comme celle qui vient d'être menée puisse être partagée. Aussi bien avec le ministère de la Femme, le ministère en charge de la Santé, et qu'avec les organisations des structures des religieux, organiser des forums, un forum national, mais avant les forums nationaux, des forums locaux dans les provinces, pour partager des conclusions, et échanger également sur des problématiques, faire reculer les préjugés. Et tout cela me semble être des préalables pour permettre vraiment de faire évoluer les comportements. Oui, j'ai regardé dans l'étude qui a été faite au Burkina Faso, il me semble que s'agissant de la demande, on a à peu près 43% des femmes, 43,5% je pense des femmes qui ont des besoins en matière de planning familial et de contraception. Mais en face de cela, nous n'avons que 22,5% de taux de prévalence de la contraception moderne. Ce qui montre déjà qu'il y a un gap entre celles qui ont l'information et qui sont sensibilisés et qui veulent et qui n'ont pas accès à une offre appropriée. Donc, comblons déjà ces gaps-là dans les pays où c'est le cas. Et ensuite, continuons donc à avancer en travaillant avec les communautés religieuses, avec les communautés de jeunes, avec etc., pour faire reculer donc, en tout cas, pour faire avancer l'utilisation donc de la planification familiale. Merci.
Thank you, Paul. So really, Roy, we've heard community ownership is very important, national engagement of the governments, culture is important, youth are important, religions are important. Are these all issues that can be addressed by the mass media, or are there limitations?
Mass media is no good at all at reaching the poorest 10% of the country. We should be really clear about that. I also think that this study shows that we didn't really have huge success with people who've got really entrenched values. I think that we're much better at getting people who are looking to be more consistent with family planning, or doubtful about it, or have worries about some of the side effects, or that sort of stuff. We can push people from the hesitant into the using very, very well. But I also think we can, you know, one of the strengths, little things can make a big difference. You know, for example, a lot of the decision making is done by husbands, and men rarely visit health centers at all. They're not going for their own health. They're not going for their children's health most of the time. And so they're never hearing the arguments. And so when they hear something on the radio and they hear a husband and wife talking about it, or the wife is given a model of how to talk to her husband about it, instead of just being told to forget about it and go away. I think that one really can make a difference with that sort of thing. And I think these sound like very small things, but just modeling how conversations can go. Or we had one interactive program where we had a discussion about whether one should go in secret to the health center and just get an injection without telling the husband. And the conclusion of the conversation was more that, you know, no, we should do it together. But there was lots of views expressed, and people need to hear those sort of views. And one of the advantages of interactive programs is that you can hear people speaking with the same hesitancies and insecurities and worries and inarticulacies that we all have, particularly when it's over something so, you know, so personal as contraception.
Thanks, Roy. And Rachel, you're an economist, and you've heard now lots of different places where investments could be made moving forward to increase family planning. Where's the best investment to make in the future? What will bring the most outcome in your view?
I mean, the estimates that we did on this show that this is, you know, one of the most cost-effective things that you can do on family planning. There isn't a huge literature rigorously testing other approaches, but it is, you know, incredibly cost-effective and much more cost-effective. This mass media approach is much more cost-effective than other things that have been rigorously tested. Having said that, it does, as Roy said, require that the supply is there. Like this, you know, demand will drive people to the health centers, but you know, you have to have the supply there to start with. I just, if it's okay, I'd like to come in on this question about the community, you know, adapting it, which has come up in some of the questions in the Q&A, but also in this discussion, because you might think that, you know, mass media is very, you know, one size fits all, and in a sense it is, right? It's one mass program, and therefore can't adapt. But I think what's really interesting about this project is, that DMI sent all the people who wrote the programs to live in rural communities before they started writing any of the scripts, to really hear what were the concerns that people expressed. So it's not your, you know, sitting in London writing the script at all. It's Burkina people, you know, spending time in villages, hearing, in rural communities, hearing what the concerns are. And then people calling in to these programs. So it is a community discussion. But I'll throw in one, but it's a community discussion that is moderated by someone who knows the facts. because the community discussions are happening all the time, but you've got someone there who actually can push back on the misconceptions. And a part of the study we haven't talked about because it's not, so related, is we gave out radios in control areas. And there you saw actually family planning take up fall. And that's because it facilitated discussions, but they were not moderated by someone who knew the facts. And so it's this, what I see is these are community discussions, but kind of done in a way where facts are brought in and into them in an effective way. And that speaks to the generalizability of a sort of, how would you take this to a new environment? You would have to adapt, the messages to what are the concerns in the new environment, but also, but we know that misperceptions about side effects is something that is very common in a lot of other countries. So that aspect of it, I think, would replicate well in other places.
Thanks, Rachel. And Darren, coming back to you, which investments do you think will make the greatest difference in reaching the 2030 goals?
Thanks, Em. So I don't think there's any sort of magic wand approach to this. There's no sort of 2 or 3 things you can say, oh, we'll do these and that'll make all the difference. I think Paul has been very wise in what he said about needing a multifaceted, more integrated approach. So we know you need effective supply, you need strong demand, we know we need a conducive policy environment. So you've got to get the basics right. But then there are 2 things I think which can really sort of put the motor on under achieving progress. And one of them is the country leadership, which we've mentioned before, and it's so important, that visible political leadership and the messaging, the consistency of messaging coming out, I think is really important. And Burkina has been a great example of that. And then this point about partnerships. At the kind of high level, we've got FP 2030 coming up. We've got the Ouagadougou partnership. We've also got the PMNCH. These are all good examples of partnerships where you get mutually reinforcing messaging, lesson learning, and sharing and support. And those things are really important. But then at the local level as well, involving the young people is so important in this agenda in particular. In mobilizing young people, and some great work going on this. Actually, I've seen some fantastic NGO interventions where they have young people who do have the facts and are informed. They're able to go out and run clubs and groups where they share that knowledge. I think that's something to look at. And the role of civil society, really important. Religious leaders too. So getting those strong partnerships in place at local level, really important. And I'm very optimistic about this, actually. I mean, we've seen in a number of countries how change can happen really fast once it gets momentum. When there's, say, the right leadership and a conducive environment for that. Thanks.
Thanks, Darren. And finally, to Alex. Alex, you took a risk on this innovation and it paid off. What's the next risk that you'll take? What's the biggest risk going forward in order to get a new innovation?
Well, the Global Innovation Fund invests across many sectors and many geographies, and it's very fortunate to be backed by FCDO to be a safe place to experiment and to take risks, smart ones, and unlock additional capital as we learn more about what has the potential to scale and to improve the lives of millions of people. I mentioned before that we're very keen on understanding this mass media to counter misinformation more generally. And for example, we're supporting some of that work now in Bangladesh to counter misinformation about COVID-19. So we will continue to watch this space and learn from all of you. And I'm eager to hear from the folks who are asking such interesting questions in the comments here.
Thanks, Alex.
Learn more things we should get to hear about there too.
Yeah, great. Well, thanks very much, Alex. And now, Amy, you've been collating some of the questions that have been coming in. And I wonder if you could pass us some of the questions so we can get the panel involved in answering them.
Sure, yeah, I'll try and group them. There's been a huge number of really interesting questions, but there's been particularly a group of questions acknowledging that, you know, demand generation is important, is perhaps the way forward, but a lot of questions that, can we say anything about what it was that made this work? What was the content of the messages that worked? Was it around birth spacing that worked best? Was it choosing as a couple together? And how was that content developed? So what were kind of the active ingredients that made this work?
Thanks. Well, let's go to Rachel to find out how she was able to. She's already told us a bit about people being in the community to develop those messages. So can you add more to that question, Rachel?
Well, I'll let Roy talk about the development of the messages, but I do think we can tell something from how people's answers changed, and how, if we compare, you know, how people are answering questions in treatment control groups, we can see what things people change their views about. And the main thing, you know, which goes to the mechanism by which this worked. And so we can't say it specifically, you know, this spot was the thing that changed it, but we do know that it was effective at changing views about the side effects. You know, it was effective in changing, really it's this whole range of sort of facts about family planning that was really different between the treatment and control, that really jumped out at us. So we have a whole range of information questions about family planning, and those all were way higher. People's knowledge about family planning was just way higher about different methods and how to use them and what the impact was. And, you know, they were just very effective at increasing people's knowledge. And I think that probably speaks to the you know, the elements of the program where you had these experts on and people could call in and ask questions. But, you know, that information was sort of a key part of all of the aspects of the program. But Roy, why don't you talk about the development?
Yes, Roy.
My first point to say is that all the messages and all the scripts were developed by our Burkina team. I should just say hello to them because I'm sure they're out there. And thank you so much for all the work that you did, because they did the work. We didn't do any of the scripts. And one thing we suggested at various points that they should go and, as Rachel said, go and spend a week living with a different family. And these are a lot of our staff in Burkina have grown up in villages. They came from rural areas. And yet the difference between rural areas that are just 20 kilometers away from other rural areas is profound, you know, and sometimes they come back with really shocking realizations about how, you know, marital relations and gender relations are structured there. And so they would then come back full of these new ideas. And then it would just go through a standard broadcasting script writing process. You write scripts, you write 10, you throw away half of them, and once you've got the good ones, you test them in focus groups and see if they're comprehensible and understandable. And if they are, then you put them on air. And then after they've gone on air, then you work out, you know, did people actually understand them? Did they actually make a difference? And then it's an iterative process that you keep on going.
Thanks, Roy. Amy, some further questions.
There's another batch of questions that are about how generalizable has this work been outside of Burkina Faso. So a couple of questions asking about places where there's a different policy environment, where the availability of services is different, and a couple of specific questions about how the program itself has been scaled up as well.
Thanks. Well, that sounds like some questions for Marie and for Paul, and maybe Alex, you'd want to say a few words as well. So Marie, I turn to you.
I'm sorry, could you repeat part of the question, Amy? I feel like some of it was about leadership.
There's a question around how to scale up in places where the policy environment might be perhaps more restrictive than Burkina Faso, or where the availability of services might be different. So how scalable and generalizable is the work?
Right, and in terms of being restrictive environments, there are a couple of countries in the OP countries that are a little more restrictive than and conservative, I would say, than Burkina Faso. And so maybe mass media in these campaigns are not the first step, and there's some advocacy and some influencing to do at the leadership level and the lower than the leadership levels as well before that starts. And that's something that the stakeholders and civil society, I think, can be extremely helpful. There are also agents of change, and I've talked about youth being those agents of change as well. And that could be a first step before we actually then get to these mass medias to debunk some of the myth and the misinformation and increase the uptake of family planning. And something that I think Roy said, or David, I can't remember exactly, is about having locals making those messages, for example, because I'm a city girl, a city person. If you ask me to write a message, just even for Senegal, I would be completely lost. It would probably just completely miss the mark. So I think those things are very important. And there are a couple of steps in those countries that are a little more rigid in terms of social norms to address that, and also dialogue with religious leaders. They're a very important component and stakeholder in our countries. They have enormous influence over what goes and what doesn't. And obviously, half the time, if not more, you absolutely need their uptake and their approval. They have direct communications to the top leadership, and we've seen some programs tank because the religious leaders, whether traditional or religious, didn't agree or didn't understand. And so something that Roy alluded to in the beginning is just being extremely honest also about what we're trying to achieve, where this is coming from. And I think putting some of these leaders at ease about what the intent is and then being able to proceed, I think is going to be very important. And then the other point about availability of services, obviously that is a huge issue. And I think that's why we tried, from the donors community, but the other stakeholders as well, to focus much more on service delivery first and making sure, and as I said, everything has not been resolved, but making sure that we have services and quality counseling as well, and getting rid of the provider bias, especially when it comes to youth, in the health centers, and having enough health centers before we start focusing on demand creation. And I think we're at a point now where we can try to do both, improve one and increase the other simultaneously. But obviously that is a huge concern, because once you've turned these women and interested them in family planning and all of the benefits of it, and they actually go to health centers, either the counseling isn't good or the services are just not of quality, or the products are not available. That is a huge issue. And I think that's where initiatives like UNFPA Supplies and others can be extremely helpful in making sure, as we say in West Africa, if you don't have a products, you don't have a program. So that's also one other area that we really want to focus on for the next couple of years. I'll stop here.
Thanks, Marie. Paul, do you want to add anything to what Marie said about engaging and making sure that this gains momentum?
Oui, oui, tout à fait. Je pense qu'au Burkina Faso, on peut retenir le fait que le gouvernement a décidé à partir du 1er juin 2019 de la gratuité de la planification familiale. Je crois que c'est important. La gratuité de la planification familiale était, le fait que le gouvernement ait décrété donc sa gratuité, c'était un signal fort qui était envoyé aux femmes, aux hommes et à tous les Burkinabés en faveur de la planification familiale. Et je pense que cela a contribué à rendre un peu plus... ce n'est plus un sujet tabou. La question n'est plus un sujet tabou pour les Burkinabés, puisqu'on parle maintenant de planification familiale, de partout. Alors, vous savez, chez les Africains, et en particulier chez les Burkinabés en tout cas, c'est des questions qui touchent à l'intimité des couples, l'intimité des gens. Les gens étaient un peu gênés. Maintenant que le gouvernement lui-même décide, c'est une question d'importance, mais toutes les questions, donc, les mesures de contraception et tout ce qui accompagne la planification familiale maintenant seront gratuites et seront financées par l'État. Ça a été un signal très fort. Il me semble que cela peut en tout cas aider à porter à l'échelle vraiment tout ce qui a été vu dans l'étude. Et je pense qu'à côté de cette décision du gouvernement, il y a également l'accompagnement. L'accompagnement de la société civile, comme ça a été dit, des organisations de jeunes, etc., qui peuvent amplifier ce qui a été fait. Mais je crois également qu'il faut que nous arrivions, en plus de ça, à faire en sorte que, au niveau, moi je le pense qu'au niveau communautaire, on puisse approcher les communautés. On puisse approcher les communautés voilà, pour les faire participer. Et je crois que c'est comme ça qu'on va arriver à atteindre vraiment toutes les franges de la population. En tout cas, personnellement, je crois que c'est par un partenariat entre toutes les parties concernées, l'État d'un côté, la société civile, les partenaires techniques et financiers, les communautés. Je pense que c'est comme ça qu'on arrivera à faire reculer les croyances qui ne sont pas fondées. Vous voyez, mon épouse me racontait que quand elle était jeune au Ghana, à un moment donné, quand elle sortait de chez elle, pour aller à l'école, partout, elle voyait sur les grandes affiches, ou à la télévision, ou à la radio, elle entendait toujours des messages qui étaient diffusés et qui étaient des messages sur la planification familiale. Alors, que vous souhaitez écouter, vous ne souhaitez pas écouter, ça vous tombait dessus. Vous étiez obligé de prêter attention à cela. Et finalement, je pense que je n'ai pas la mesure des résultats, mais c'est ce type aussi de politique qu'on peut tenter de mener et qui certainement aura un impact sur le comportement des Burkinabés et de manière générale, donc en tout cas des pays de la zone du Nord. Voilà un peu ce que je peux ajouter. Je pense que tout cela, c'est une action qui peut porter ses fruits, mais il faut vraiment une action concertée de tout le monde. Merci. Je pense que, alors, DMI, de ce point de vue, me semble peut jouer un rôle encore plus important en se rapprochant davantage des autorités gouvernementales, notamment le ministère en charge de la femme, le ministère en charge de la santé, et tous les ministères qui sont concernés, et pour essayer donc de vraiment tirer des synergies entre ce que le gouvernement fait à travers le plan national d'accélération de la planification familiale et ce que les partenaires techniques et financiers peuvent nous apporter. Merci.
Thanks, Paul. And Alex, just to you for a final few words.
I'll just say something briefly about these sets of questions coming up around generalizability. And I'm sure Rachel can correct me on what I get wrong here, but I would really urge the audience to not think about randomized controlled trials as like a red light or a green light. And we have one result from Burkina, and now you know you can scale that up in Senegal. And to rather think about this as grist for the mill that helps you improve your thinking. If you understand what seemed to have worked well in Burkina, while really getting very close to the communities and developing messages. You know, what kind of things did you see out of this? How might that then inform what you do in other contexts? And it's a bit of a straw man to suggest that anybody would ever say, okay, this means green light, now we do this exact same thing all over the continent. And instead, this is grist for the mill while you're thinking about, in a different context, what might be similar to Burkina, what might be different, what seemed to be the secret sauce of DMI, can we incorporate some of that there? And note at GIF, at FCDO, if I may be so bold to say, and within DMI, these are one piece of information to help sharpen your thinking. And it's not, nobody would say that this is a red light, green light kind of a matter.
Thanks, Alex. Rachel, do you want to react to that?
Yeah, I think that's exactly right. And I think also the findings aren't a red light, green light either. There's a huge amount of detail about what people responded to and where they changed their views and where they didn't. And I think that helps us inform. So, and just to say, if you're interested in that detail, the paper is publicly available, and it's a working paper on the Oxford Center for African Economics. So you can find it there. I think it's probably also linked on the DMI website, and because there is a lot of detail that we learned about what people changed their mind on and what they didn't change their mind on.
Thanks, Rachel. So I think we need to begin to bring this session to a close. There have been some really interesting discussions. And before I come back to the panel and ask each of the panel members to say one final word, very precise, but one final word about the message that they would like to leave with the audience, I'd just like to try to summarize what I believe I heard. And I heard three major things that need to be in place in order to really move ahead through the Ouagadougou project and others as well. And the first is creating demand. And we've heard how DMI can contribute to that, along with other interventions, to make sure that there is a demand for products. At the same time, ensuring, and this is a government function or a civil society function, to make sure that supplies are available when that demand is created. And finally, the biggest task is to engage governments at both the national level, possibly at the regional level, but certainly the traditional leaders, the religious leaders, youth, and communities and others in really moving ahead with the right understanding of how family planning can really contribute to a better life for them and for their economies and their countries. So I would just like to now turn to each of the panel members, and I'll start with Alex this time. Alex, if you could just say a few words about messages that you'd like to leave with the audience as this panel comes to an end.
I think I'll just say very briefly that this is a great example of how to use a powerful combination of deep, culturally sensitive, localized, qualitative work with rigorous quantitative work to identify promising, cost-effective solutions to be part of a multifaceted approach to an incredibly important development problem. And I think collectively it would be great to see more of this in the world, and it's certainly something that will inform us at GIF about how we seek out innovations to test and to support the scale up.
Thank you, Alex. Darren, final word from you.
Yeah, thank you. So I think all I really want to say at this stage is that the UK will continue to champion family planning and SRHR. It's really important to us. It speaks to our values on gender and rights, and we recognise how critical it is to achieving many of our development objectives as we continue to support country leadership in determining their own development paths. I think this study, which we're really proud to have been associated with, has been great work by all those involved, has really given us some very valuable insights. And that will help us inform our programming in the future and make that even more effective for the needs and the purposes and the benefit of the people that we ultimately serve. So thank you.
Thank you, Darren. Rachel, over to you. Final few words.
Thanks. So I would say that, as we seek to empower women to take control over their own fertility, what we've learned is that knowledge is key to that empowerment, that mass media is a highly effective tool for doing that, and particularly a highly effective tool for doing it cost effectively. And as we're in constrained budgets, that's really important if it's done well. And I think you have to remember that this is, this was as we've heard about, a saturation campaign with a lot of local adaptation. So, so knowledge, mass media, and cost effectiveness. Thanks,
Rachel. Marie.
Yes, thank you, David. Maybe what I can say is that change is never easy. Right now, our greatest challenge at the Ouagadougou Partnership is helping cause productive dialogue between older, more traditionally conservative generations and the growing and vivacious youth cohort that is increasingly interested in controlling their own reproductive futures. As we said, about 50 to 60% of our population are under the age of 25. And so we absolutely need to include them in these sorts of initiatives. Thank you.
Thanks, Marie. Paul? your final words.
Merci. Merci beaucoup. Je n'ai plus grand-chose à ajouter à ce qui a été dit. Ça me semble avoir été très bien résumé. Je voudrais en tout cas dire ma satisfaction et dire également que c'est la base des conclusions, qu'il y a beaucoup de travail, il reste beaucoup de travail à accomplir. Ça a été résumé aussi bien du côté de l'offre, donc du côté du gouvernement, mais également du côté de la demande, notamment à travers l'action de structures comme DMI. Je pense que ce qui a été fait prouve qu'il reste beaucoup encore à faire pour atteindre la grande majorité donc, des populations qui ont besoin d'avoir l'information et qui ont besoin de pouvoir également changer leur comportement en matière donc, de planification familiale. Alors, je pense que c'est notre engagement à tous de travailler à cela, tous ensemble. Et je pense que c'est ce que nous ferons dans les jours et dans les mois qui viennent. Je vous remercie.
Thank you, Paul. And finally, Roy, over to you.
Yeah, thank you, David, for chairing this so ably. We talked a lot about mass media, and really mass media is just a vehicle. This is about human knowledge, and all of us, for our health, for our well-being, for our ambitions, for our life goals, we need to know more. We need to have this basic knowledge, and family planning is such intimate knowledge, so difficult. We all went through this stage of really not knowing what it was all about. And so I think we owe this to people. I'd like to say thank you to the Global Innovation Fund and to our anonymous donor and to USAID for funding the study, for helping it to take place. We're really grateful for that. I'd like to say thank you to our anonymous donor and the FCDO for helping us scale up in altogether 8 other countries. That's been great. I'd like to thank once again our Burkina team. They're just such brilliant people to work with, and we will always be indebted to them. And thanks to all the people who came along and asked questions today. I'm conscious we didn't get through to all these questions. I will try to answer some of these questions before the line goes dead, so that you will get some answers to some technical questions that we weren't able to cover. So I'll try and do some of that before we go home tonight.
Thanks very much, Roy, and thanks to all the panelists, and thanks to the audience, and thanks to our very excellent interpreter. I think we've had a very interesting session, and I would just like to thank everyone for having participated. Et à nos collègues en Afrique, merci beaucoup. Et à bientôt, j'espère. Thank you.
Thank you, everybody.